standing in front again. We utilize, I have a lot of our big events, things that come in. He's kind of our guy that we'll put on call, like the NCAA tournament, which we've obviously have quite often that comes into town. So he is our go-to for that. He's a wealth of knowledge and kind of the person that you want to be talking to when you're dealing with the face and or dealing with suturing injury type stuff in regard to that. The best thing, one story that I will quickly tell is coming from the college setting. I had one of my hand surgeons that's husband was basically was a plastic reconstructive surgery physician. And you never know really how handy that truly is with your athletes until you get these big facial lacerations and really need somebody that knows what they're doing. So, Dr. Stallworth, greatly appreciate you being here.
Thank you. Thanks for having me. So, as Sean just said, yes, I'm a facial plastic surgeon. I'm board certified actually as an ear, nose, and throat and head and neck surgeon first, and then separate training in facial plastic surgery. I actually went to college here at Trinity, and I've been practicing in San Antonio now for almost 13 years. So I was in charge of the facial kind of plastics and trauma team for the San Antonio Rampage for about 8 years, and then I've probably crossed paths with some of you or some of your athletes at different times. I am a faculty at the Health Science Center, and I'm also in private practice with Texas Plastic Surgery. Some of you may know Jaime Garza, and he was my colleague, and I took over his practice. So I don't have anything to disclose, nothing I'm going to present today I have any financial or other conflict with. Some of the things I want to go over with you, when Sean talked to me about this talk, it was trying to give you knowledge about how to deal with some of the injuries you might see and try to not only manage them yourself, but also determine when somebody else should get involved. And so one of the things he wanted me to spend some time on are just the basics of wound healing and suturing. And some of this I don't know really how practical it will be in terms of what you feel comfortable with, what supplies you have on hand, medications you have to administer. But I'm going to try to go through some of the basic things that that I would see. These are things that we would do on site at places like the AT&T Center. And some of you may have access to it in your training rooms. But talking about the basics of closure, and then I'll show you, at least in the head and neck, some different subsites with very specific clinical findings that would maybe spark you to escalate care. So this is from a chapter I just wrote this past year, and this applies to everywhere in the body. It's not just the head and neck. And a lot of what we do to manage wounds is based on this timeline. Sutures that we choose, trying to prevent infection. And as you can see, this is a log scale. So everything that's to the left, you have an immediate wound, you have bleeding, your body's going to try to stop that bleeding, try to close down the wound, and try to clean the wound simultaneously. But that's really happening in hours to the first few days. The third phase is a long, protracted phase that's going to take you out a year. And there's no way around that. And definitely in today's world with things like TikTok and social media, particularly every young patient I get wants to have something that will speed that process up. And there isn't anything in science that can do that for you. So looking at this sigmoidal curve that goes here about tissue strength, a lot of the sutures and different closure techniques that we use are trying to mimic that and give you tissue strength when you don't naturally have it, but fade away or be removed once you get that natural strength back. And for us, really, when it comes to major emergencies like an airway problem, a true like CPR situation like with the NFL this last week, obviously the airway is paramount. But when it comes to more minor wounds, I mean, the first thing is just to stop the bleeding, just with pressure. And I think we all kind of do that to ourselves when we have a wound. And then cleaning it really well. I just had a partner, well, not a partner, but a colleague here in town whose son is a high school quarterback, had a major facial injury about 3 or 4 weeks ago. I got to see them about 9 o'clock at night, and she just wanted me to close the wound. The problem is that all of those little rubber pellets from the field were down in his cheek, about 2 centimeters below the laceration. And so one of the things that we see are wounds that are closed, and then you have these delayed complications. And a lot of times it's from foreign bodies. It can be grass, dirt, road rash, anything, cloth. So really irrigating and cleaning wounds is really critical. And then for us, preserving function, and scars are less of an issue. You can always come back to fight another day. And revise a scar as long as you maintain those things at the top. If you don't do anything to a wound, it's generally going to heal, particularly in a young person and someone that doesn't smoke, who's not diabetic or have other immunocompromises. The problem is it's not going to heal great. And so one of the things that leads to scarring is tension on a wound. And so when you have something that gapes open, there's not something bearing the load to try to pull it back together. It's like you've cut an elastic band and the 2 sides snap apart. And so the body will heal that, but it's going to lay in a very thick layer of connective tissue and scar into that wound bed, filling it with fluid. That can be a place that leads to infection. It obviously may impair function, doesn't look great. And the cells that form scar tissue, fibroblasts, actually work like little muscle cells, little myocytes. And they actually grab onto things and contract to try to pull the wound together. So you can have just think about like skinning your knee or having a more superficial but large surface area wound. It will heal in over time. The key to that is keeping it wet. So when you're talking about really simple things, again, I think cleaning it is really important. And the reason I put anesthetics in there is because cleaning can really suck. Particularly when you have, like when we see people in the ER that have got a very superficial wound, but say it's road rash from a car accident or something, and you've got lots and lots of gravel and dirt and something and have to scrub it. I mean, it's really, really painful. And so before I try to clean something, if I can anesthetize it, that's what I would do. And again, I don't know if you have access, but even topical things like Bactine I think are great, which I've used at home. And give it a little time to work. And so cleaning, even manually scrubbing or removing things, and then high volume water. There's all kinds of, in our surgical world, there's people that have different voodoo that they like to mix in antibiotics or betadine or Hibiclens. And really, the thing that is the statistical thing that shows that you can decrease contamination in a wound is just volume. And so just putting normal saline or sterile water through it is more important than anything. If there's nothing else I teach you today, I hope that you will stop using Neosporin. So it's on the market and it's been around for a long time, but if you look statistically, about 20% of every human being will form what's called a type 4 skin sensitivity to it. And when it happens, it will look terrible. It will look like it's infected, and it will look like someone's got poison ivy or poison oak, and it often will spread out beyond the wound. And so it can actually happen with anything topical, and particularly when it's applied over a long period of time, over and over again, and bacitracin will do it too. But bacitracin is just in the plastic surgery, dermatology world, if you're going to use a drug, we'd much rather use bacitracin than Neosporin, particularly on the face. And more than that is just keeping wounds moist. This is a picture of essentially what's called granulation tissue, or all these new little blood vessels that have filled into a wound. And you can see the skin, the epithelium, hasn't grown across it yet. That's the ultimate goal. But if this dries out, it will form a scab, and that migration of those skin cells will stop. And so the most important thing for a wound is moisture. There's a lot of different ways you can do it. If anybody's had a tattoo, if anybody's had a scrape. You also have mobile areas that dry and contract. If you have a knee and elbow and those things just continue to fester, keeping moisture there is really a great way to promote the healing. And once the skin is completely healed over, the only thing that has been scientifically shown to improve a scar is topical silicone. So you can put Mederma on it all you want. That's all it is a moisturizer. And there are things like vitamin E and cocoa butter, and people swear by all kinds of things. But silicone is the only thing that has any statistical evidence to improve a scar. It does two major things for you. It makes the redness go away faster. And redness actually can be one of the things that makes a scar much more visible than the scar itself. And it will cause the scar to flatten. So things that make scars unfavorable are when they're either raised or depressed. And if you can get the topography flat, that also takes a lot of the unsightliness out of it. We don't know why silicone works. We think it forms almost a greenhouse against the skin. So your normal perspiration is going to trap water molecules between the silicone, and it's essentially doing moisture, which is what you had with Vaseline or Aquaphor. But it's going to give it to you in a much longer period of time, much more directed, and it's definitely not as greasy or messy, and you can't see it, and it doesn't have a color to it. So it's great on the face. They make silicone, you may have seen it in very large strips. You used to have to get it as a prescription. Now you can get it pretty much any Walgreens, Walmart, CVS. They make it in sheets for larger body wounds. So if you had a shoulder wound or a chest wound, or somebody had their ACL repaired, those kinds of things are going to be more effective than trying to put this gel on there. So again, for major lacerations, managing bleeding is obviously first, and pressure is critical. And I don't know if you've ever, I still have it, and I operate all the time. You hold pressure and you think you've held pressure for a long time, and it's maybe been 10 seconds, particularly if there's a lot of blood or you're concerned about it. If you can hold pressure and kind of count in your mind 30, 60 seconds, it's really not that long, but it gives everything a chance to work, all your normal innate things to clot. So again, try to anesthetize a wound if you can, and then irrigate it, irrigate it, irrigate it. The big thing then for managing a laceration is determining what the depth of the wound is. If you can see fat coming through it, you know you've gone through the dermis. And that's going to need more tension-bearing closure. A note about puncture wounds, they really shouldn't be closed. So particularly things like bites, but it can happen from just about anything, a stick, a nail, any kind of projectile. Most of the time, those are problematic because they've inoculated the tissue much deeper than you can get into to clean out. And by closing it, all you're doing is trapping anaerobic bacteria in the wound. So, and some of that depends on the time frame for when it happens. If you're able to see them right then and clean it out, then it may be okay. But in those cases, you really want to try to get like a little catheter, some little straw, coffee stirrer, something that you can put down in the wound and irrigate it out. And then trying to make the decision, do you suture it, steri-strip it, glue it? When I talked to Sean, we talked about doing like a suture workshop. It's just not feasible in this time frame and with the volume of people. You can get this on dozens of websites for free. You used to have to get it, when I was a general surgery intern, you'd have to get it from a rep, and it came as a big manual. Now you can get it in a PDF online. If you just search for Ethicon Suture Manual, you're going to get this 70-page manual that has everything you would want to know about suturing, tying knots, needles. Many of these diagrams I've brought out are from this manual. Ethicon is one manufacturer. It's like, Coca-Cola, and then there's Covidien, which is Pepsi. It's just one of the big ones. But you can learn a lot just from looking through that. So if you have an interest in it, I'm going to show you some different things from that manual, but you can do a lot of self-learning. That's pretty much what a lot of residents and fellows do. When it comes to suturing, one of the things we wanted to make you aware of are what kind of sutures you may see in your practice when you've got athletes that are coming back to you. And there are sutures that are in all of these categories. There are things that are permanent and those that absorb. So usually if they're black, they're blue, they've got a color to them. They're like, you can think of them like fishing line. There are some things that are braided that look like polyester. They may be green, but they're usually going to be some color. They're not white or pale. If they're more of that iridescent, clear, flimsy, like a blonde hair looking thing, those things are going to fall out on their own, usually in about 7 days. Braided sutures are going to be stronger, but they also cut through the skin like a rope. So we usually use them deeper under the skin for things like dermal closures. We'll talk a little about sizes. Needles are important. When you're looking at sizes, just so that you're all familiar with nomenclature of suturing, it's essentially a French ratio from long ago, but on the left-hand side in the United States, you're going to see sutures that are classified by 10, 20, 30, 40. Essentially, that's a decimal point getting smaller and smaller and smaller. So actually, a 7-0 is exponentially smaller than a 1-0, if that makes sense. And as you go down this list, the finer and finer they become. They're also weaker. They have less tensile strength, but that's why we use them for things like nerves and the cornea versus something where you're closing like the thick dermis on the back or somebody's belly wound. And so we determine which kind of or size we use based on those things. In the face, generally, I would prefer nothing bigger than a 4-0, usually a 5-0 or a 6-0 on the face, and I'll get people that come in from ERs with a 1-0 with these two, big things holding it together, and it's a little overkill and bad for scarring, but at least it got it closed. Generally, you want to place sutures and close a wound within about 12 to 18 hours, as long as you can get it really, really clean. So it's not like the minute it happens, it has to get fixed. But the longer and longer time goes on, the more and more the risk may be. And then sutures are generally, in the head and the neck, are going to come out in about 7 days, maybe 5, maybe 10. But not longer than that. But as you get lower into the body and the dermis and the skin gets thicker, you're going to have suturing that may need to stay for a couple of weeks. This picture is from the manual, and as you can see, there's a superficial part of the wound, and then there's a deep part of the wound, and then there's what we call dead space in the middle. And one of the problems I see from suturing that is done is that you've got a wound that is deep, and someone puts surface sutures, but you don't close that dead space down below. So you've got the whole thing bearing the load by just the thin skin on the surface. The muscle and the fascia has been split down below. The wound can pull apart or break apart, but also it'll fill with fluid, and fluid leads to things like pain, and it leads to infection. The needles that you will see, I would think that anything that you guys would ever use should be some form of a cutting needle. So you will see needles that are called taper needles. They're essentially like a blunt sphere that has a little sharp point on the end. They're very hard to drive through thick skin. We use them in things like the intestine or the lining inside the mouth or sewing like a nerve together. But you need something that's going to actually be able to create a precise cut through the skin. And then there are things called cutting and reverse cutting needles. When you grab a needle, this fob back here, the eye where the thread comes in, if you grab it right here, you're going to break it off. And so you can wind up leaving it in the wound and then not be able to get it back. And if you grab it too close to the tip, you blunt the tip, bend the tip, and you don't have as much degrees of freedom to place it. You're going to see suturing that can be running like a baseball stitch. You'll see things that are locked. I'll show you a picture of that in a second. Maybe interrupted sutures. Running sutures are great because you can get them in faster. It's all one thing, less downtime, but if the whole thing breaks, then the whole thing unravels. You can put in lots of interrupted sutures. It takes more time, but you're not then putting all your eggs in one basket. I think taking them out, I don't know if it's an inherent thing. I have it even with my residents. They'll come in and they'll cut both ends of it and then pull this thing. And all it does is kind of crimp the tissue together, and you keep pulling it harder and harder and harder, and it hurts. So just taking a scissor and like clipping here, clipping here, clipping here, clipping here, and then these little segments just pull out without any resistance. These are again from this manual. On the left side, we're talking about simple stitches. So suture or a wound that just basically goes through the epithelium, maybe into the dermis, but not really deep. You're just placing a superficial stitch to hold that together. One thing you'll see is all of these needles on sutures are arced, and you want to try to follow that arc, and you want to enter the skin as perpendicular as you can. If you kind of sky the cross, you're not going to get the depth, and you won't have the two ends of the suture parallel and lined up so that you get a nice closure. On this side is showing you placing what's called a deep or a buried stitch. So in this case, you want to close the dermis. The way the suture is being thrown, it's being thrown from deep to shallow and then shallow to deep. And what that winds up doing when it's closed is it leaves the knot as far away from the surface as possible. Everything you put in here is now a new foreign body. And so if you have a contaminated wound, you have bacteria, everything on that stitch is surface area for something to grow on. And things like knots, the body will try to spit out. You may see that in wounds that come back, and people that have had it closed, particularly in the face when the skin is very thin, you'll see these little white, looks like cotton threads coming through the skin, and that's your body trying to push that out. Most often, if you grab with just a tweezer, sometimes not even any force, it just comes out because the body's already broken it down and is trying to eject it. So this is another thing that you may see in closures, and patients, whoever the recipient is, may not like it. But when a wound is closed, it should not be flat. So when you go out to see when I was training, I always loved how I could get it looking nice and flat, and family thought it looked gorgeous, and that turns out to be a terrible scar later on, because all of these wounds are going to retract from one another. And so if you have something that's perfectly flat when it's closed, it's going to retract apart and depress. So the edges of the wound should be everted or pushed up like this, and there's different techniques to do that. The guy that trained me always talked about, praying hands coming together, and you want the two edges of the skin to kiss and to push upward so that when they do contract, they lay flat. This is something that you may see, which particularly in a lot of orthopedic wounds and skin that's thicker and must bear a load, would have what's called a mattress suture. And essentially what's happening is the suture is being placed superficially and then back deeply and tied on one side of the wound, and it will push and mate those two sides together. And a stitch like this can take the place of that deeper suture. So it's going to be a lot stronger. I don't know if this is going to play or not. Give me 1 second. See if it'll get on my phone. Well, you can find these videos of suture placement online, and they walk you through how to load needles, how to manipulate them. And if you are interested in suturing, you got to practice it. And there's now online, there's a million things you can buy for yourself through eBay, through Amazon. There are these suture models. There are fake skins. You can buy cheap sutures to play with. I would start with something big so that you can see it, almost like tying a shoestring. You don't want to start out trying something really fine. You can buy instruments online, cheap stuff on eBay. One of the best things that we use that's readily available are pig's feet. So you can go to any H-E-B or any butcher and they will give you pig's feet pretty cheap. And when they are thawed out, you have skin, you have a fascia underneath it that moves around, and you can basically create wounds. Just cut something and then practice sewing it together. Is a big one for residents trying things, and one of the hardest ones is really to peel an entire banana and then try to sew it back up, particularly without the fruit inside it. It's tough. When it comes to wounding, you've all seen that we all have wrinkling on our skin, and what that comes from are something called relaxed skin tension lines. So our skin is going to preferentially wrinkle in a certain way based on the way that collagen fibers are aligned and the way that the muscles are aligned. And everything in this side is how the skin in the face would normally wrinkle, and those wrinkles are always going to be perpendicular to the way the muscle pulls. So like the muscle in your cheek that goes from your lip here to cause you to smile, as it pulls this direction, you get a line that comes to it parallel. If you can close any incision, or if you have a wound that falls parallel to those lines, it's going to be a lot more favorable and have a lot less tension on it, and it will ultimately be a lot better cosmesis. If you have something that cuts against the grain, that can be a big problem. We also compartmentalize the face and the entire body into these subunits, and if you can have scarring that falls along the edges of these things, it will also be more favorable, but that it also shows you that there are changes. Like if you look at the skin around the eye, every one of us, our skin around our eye is going to be the thinnest skin on your body. Yours may be different than mine and his and hers, but if I look at your body, your lower eyelid skin is going to be the thinnest skin on your body. Next is going to be over the bridge of your nose, generally. There's no fat there. Then you transition into the cheek and you got lots of fat. So you have these transition zones where the skin changes as well. To talk about some specific subsites in the face, the lip and the oral cavity are common places I see injuries. When it comes to the lip, probably one of the most talked about thing is trying to line up the vermilion border. So basically, the transition between the skin tone and the red lip, if that is off by about 1 to 2 millimeters, it'll be seen across the room. It's just the way our eye picks up on things and the way that light shadows against it. So that is one thing that needs to try to be precisely realigned. Again, if you can't and it heals and there's a scar, so be it. You can come back and fight another day and revise it, but we do want to try to line that up. Within the lip itself, our lip has a dry area that transitions into a wet area. Those lines we want to try to line up. If you have something that is isolated to the mucous membranes, to the red lip itself that doesn't come out of the skin, you have a puncture inside the mouth from a bite, a lot of times those don't need to be closed. They're going to heal on their own, and as long as they keep it clean, keep food out of it, it's going to heal in. When you have something like this, though, that splits the entire lip, goes through the muscle, that's a much more complex problem. Now you've got a functional problem and an aesthetic problem. Again, here, the skin tone of the lip has been closed with a permanent stitch, which is a Proline. The red lip has been closed with a dissolving stitch, and there's actually deeper sutures that also dissolve that are in the muscle. We take these out in about 5 days. And now, at this point, it's still very pink, and now you're back to managing with moisture and then silicone. If you have somebody that's got an oral injury, though, and their bite does not fit, so they say their teeth are off, if they cannot open their mouth as well as they should, and they have pain and particularly numbness of the cheek or the chin or the lower jaw, these are all kind of warning signs. You've got a jaw fracture potentially until proven otherwise. So those are things that I think you should be aware of. I know that Dr. Macias is going to talk, and he's going to tell you a lot more than me and is a lot better at it. But I can tell you, at least from the oral surgeons I work with, if you have a tooth that is loose, if you can just gently keep it in the socket, it's attached to a periodontal ligament that's going to give it its nourishment and keep the tooth alive. Don't try to cram it back in with a lot of force. At the same time, if it's really loose and it's going to become a foreign body and they're going to aspirate it or swallow it, then it needs to be removed. If you can place it in milk, that is thought to be something that helps maintain the pH and the health of the tooth. I'll defer that to Dr. Macias. But it is something that can be salvaged. And so getting them in with a dentist right away to have it splinted is key. I want to spend a second on nasal fractures because this is one of the things I see the most. And it's also something that I think a lot of people, and definitely parents, don't or they freak out about a lot. A fractured nose is not cancer. It's not going to kill you. It can affect your breathing. It can affect the way you look. I don't need a CAT scan. I don't need a plain film. Plain films are absolutely worthless. So I have athletes, patients that come in all the time that have an x-ray that shows that there's a crack in the bone. That's a two-dimensional thing. You see the crack, you look at them, they don't have much bruising, their nose is straight, they're breathing fine, they never bled, they got an x-ray, there's a crack there, everyone's worried that there's a fracture. So then everybody wants to get a CAT scan, which is a lot of radiation for the face. You don't need it from a clinical standpoint to tell someone's nose is broken. If their nose is bleeding, if their nose is crooked, if, you can show it to your child and they would say, yes, this nose is broken, and no, this one is not. Swelling is a big problem with noses, though, because it clouds things. It can make it look like it's much worse. It can also make it look like it's pretty good and not bad at all. So the only time we intervene on a nasal fracture is if it's impairing their function, so they've got a new problem with breathing, and if they've got a problem with cosmesis. There's another big problem potentially with some of your athletes, and that is their age. So the facial skeleton in young women is going to not reach its kind of terminal growth until probably somewhere between 15 to 17 years old, and in men that may be closer to 20. And during that time, if you intervene on a nose in a very early age, say in elementary school, junior high school, you can actually stunt someone's mid-face growth. So you wind up with a 6'5", 300-pound guy that has this very short, stubby, infantile nose with an underbite because this never developed because an ENT tried to do a septoplasty on him when he was 5. This can happen from bad trauma, too. And so we do want to talk with families about that depending on their age. If a nose is broken and off, the absolute best time to intervene on it is right then. The problem is that a lot of times either you don't have somebody that knows how or is comfortable how, or having someone around. You know, kids on the basketball court and there's no adult around, something happens, they come home and hours later someone sees them. By then the swelling sets in and it's very difficult to see what's going on or to manually feel it. So we either reduce things immediately or we want to reduce them in about 7 to 10 days. Because at about 14 days, you've got a fibrous union between the bones and it's going to become very difficult to move. And by 28 days, we consider them solidified. There's a lot of problems. If you're just looking at nasal fractures, think about this triangular pyramid. You can have one side fractured, you can have things that are concave. But these bones that sit like a tripod, when they move right and left, they usually fall inward. And so you can try and manipulate a nose with, because that's all we do, is manually move it back. The problem is that if it's moved over and fallen in, the only way to get it back is to pull it out, disimpact it, and move it over. So we usually use little blunt instruments like this and some bimanual palpation. When I do something like a rhinoplasty, we are actually cutting the bones of the nose and frequently can't see where those cuts are. All I want to do is be able to mold the nose where I want it and let it heal that way. You can't put plates and screws and wires into these bones that are about the thickness of an eggshell. But they are attached to the skin envelope, the lining inside, so they're not going to just fall someplace. And if you can manipulate them back into position, they're going to heal. So I get somebody like this that comes in, he's bruised across the bridge of his nose. His nose looks a little off. You look at his base, it's leaning over to one side, and here you can see that one side is more concave than the other. And what will essentially happen in this case, if you let it heal, is that his right side, that side, will wind up, if you were to measure the distance from his cheek to the apex of his nose, and then from the apex down to this cheek, this side is going to ultimately be longer because this side has fallen in. So to get his nose straight, you have to pull it up and back to the midline, and that's something that can be done in the clinic. And I do a lot of this under local anesthesia. I've even done it in kids. It really depends on their maturity, the family, and if they'll tolerate it or not. Otherwise, we take them to the operating room. When you have a nasal fracture, again, pressure, management of bleeding, two of your biggest friends are Kleenex and Afrin. So oxymetazoline or phenylephrine, which is things like neosynephrine, a number of these just over-the-counter, cheap, vasoconstricting. They're nasal decongestants, but the way they work is they cause vasoconstriction of blood vessels, which shrinks the lining down and helps you breathe. But if you've got an acute bleed, and even in the operating room, this is what cocaine does. It constricts the blood vessels, and so you'll slow the bleeding down. If you have bleeding that's coming from one side, if you have something like a dental roll or even just Kleenex that you can kind of spiral up and soak in Afrin and plug it in the nose, you're going to generally get pretty good control. Now sometimes obviously that doesn't happen and the nose has to be packed. But starting with management of bleeding, don't have people hold their head back so that they aspirate and swallow blood, bring their head forward. If you've got a bulging septum, so if you look into the nostrils and there's this pink tissue that is emanating on both sides, that's concerning for what's called a septal hematoma. And then if there are other symptoms associated with it, particularly with central face injuries or upper jaw, like I broke my nose but now my teeth don't fit. I broke my nose but I have double vision. These are concerning that you've got an associated fracture with the nasal fracture. So if you see this inside the nose, this is essentially, in our world, an emergency. So that fluid has got to be drained or the cartilage of the septum will die. And much like what happens with a cauliflower ear. So the cartilage in our body has no blood vessels in it. It only gets its nourishment through diffusion. So there is a layer on each side of every piece of cartilage that allows oxygen and nutrients to transport across it, and when you get bleeding under that layer, it strips it away, and then the cartilage is starved. The cartilage dies, it scars, and in the nose, everything collapses. So generally, we have to drain these and then try to pack them or sew them together. Again, Afrin and Kleenex are your friend. When it comes to ears, we're trying to prevent these guys. On the left is, you can see the ear is red, but the earlobe is not. So if you see that, that's consistent with something called chondritis. So they don't have a cellulitis because if all of the skin was infected, the earlobe would also be red. But we don't have any cartilage in the lobe here, it's just skin and fat. And so this is also a problem. And you can have superficial wounds that go untreated, and if you get bacteria in that infect the cartilage, that's a real problem. The only antibiotic that penetrates cartilage are fluoroquinolones, something like Cipro. And I don't know if any of you have read about fluoroquinolones, but one of their problems is they lead to things like tendon ruptures, or that's one of the things that they can predispose to. But that's generally one of the only things we're left with to try to treat a chondritis. On the right is a hematoma or a seroma. So you've got fluid that's collected between the skin and the cartilage that's blunted those landmarks, and that needs to be drained, and then somehow the skin has to be mated back down to the cartilage. I have seen these. I've had athletes, UFC fighters, a police officer bring these in to show me these magnetic compression devices for ears. The problem with them is that I've now seen the opposite happen, which is somebody that puts this on and then the compression is so great it leads to necrosis. But I think in the short term, anything to try to eliminate that dead space and keep it from draining is key. So again, with ears, cartilage exposure, obviously if an ear is avulsed or a large portion of it is missing, we need to get them in. And then finally with eyes, there's lots of stuff I see like this that really doesn't even need maybe a Steri-strip, maybe some Dermabond, but this is falling in line with the normal creasing of the eye. Again, there's not really any fat in the eyelid. The skin is exquisitely thin. There's no tension in it. And if there's no other ocular symptoms, a lot of times something like this is just like a glorified abrasion. You split the eyelid, though, now you've got a new problem, because our number one goal here isn't how it looks, but it's protecting the eye itself and the cornea. And if someone can't close, the cornea will dry out and keratinize, which can ultimately essentially blind them or decrease their vision long term. So in these cases, just keeping the eye covered, moist so it won't dry out, using natural tears, lubricating gels until someone can get to see them. If you have any injury around the eye and somebody complains of double vision, a loss or change in vision, those are big hallmarks that you may have an entrapment of muscle, and you may have a fracture that needs to be tended to, and some of those can be more urgent. This is a subconjunctival hemorrhage. You may have they happen to people sometimes spontaneously. If you take aspirin, or you have stress, or you're working out, you may blow a blood vessel in the eye. But in a traumatic situation, this is a hallmark sign for someone having an orbital fracture. Generally, if someone doesn't have one, it doesn't mean that they do have an orbital fracture if they've got a bleed under the conjunctiva of the eye. But if they don't have any blood, they almost never are going to have any kind of fracture of the orbital floor or the walls. But if they do have it, it's something to suspect, and an easy test is just to have them follow your finger and look in all directions. And if they move everywhere, nothing is at least entrapped. But you will find people that move, and then they go to look up, and both of their eyes separate, and they become instantly nauseous, they have a lot of pain, and say that they see double. That's a problem. You can also just feel both sides, the normal side and the traumatized side, and you will feel step-offs in the bone, particularly before the swelling onsets, and that can really tell you what's going on. And then if people have numbness, so there are major sensory nerves coming out above the eye, in the forehead, below the eye and the cheek, and at just to the sides of the chin, below the corner of the mouth. And when you've got trauma in an area like that, and then you have a large field of numbness associated with it, it's very likely that the bone underneath has been broken. And then lastly, something called a hyphema you may see. So blunt injury to the face or around the eye may not break anything. There may not be a laceration. But if you see this meniscus with blood, that blood is in what's called the anterior chamber between the cornea and the iris. That is an an ocular emergency because that blood can clog the outflow system for the fluid in the eye and lead to essentially what's called glaucoma, like very rapidly, and can cause vision loss. So that's something that needs to get in to see an ophthalmologist immediately. So that's all I got. It's a lot of information. Anybody have any questions? Yes, sir. That's what I would do. So if I was on the court or with you and we're in a match and somebody gets an immediate fluid collection under there, I would sterilize a needle or get a sterile needle or even a sterile blade. Problem with the needle is that once you puncture it and suction it out, it may just keep reaccumulating, and that little hole's not going to allow it to drain. And so even if you have a little scalpel or a bigger needle, like an 18 gauge needle, which is almost like a little blade, and you can punch in and even take the bevel of the needle and make a little 2-3 millimeter cut just so that you can squeeze all that fluid out, that is great. And then put antibiotic ointment on it and try to compress it some way. Like the magnets, but even putting just like gauze and tape on it to try to prevent it from being able, you can walk around, they could walk around holding pressure on it, but they're not going to do that for a long time. Something like that, safe, again, the concern is making sure you don't cause necrosis there for a long time. But generally, once the bleeding stops, you're going to take it off, and that's going to go away. And that's going to be better than leaving it there. One of the problems with fluid that is left for a long time, so let's say that happened and they came and see me 2 days later, that fluid is congealed. That blood is like formed a clot. It's like jello in there. Now I've got to try to make a bigger incision. Sometimes it's kind of permeated into all the tissue. I can't get it all out. Then you use heat. You wait another couple of weeks to see if it'll liquefy and then try to get it out. And then by then it may be too late. Well, as long as I think as long as I would try to do it that day. No, you can still try it. I'm just saying, I'm saying that like you may get to a point where you try it and nothing comes out. It'll feel blottable, like a little water balloon, and then over time it'll get more and more firm. And at that point, you're probably not going to get it out easily without really cutting it open.